Okay, during the diabetes type 1, we're going to do the second part of inborn errors of metabolism, which is fatty acid oxidation disorders. One of the major reasons we've decided to do this is there's just too much material to put in one case, which you guys probably already know. So how are we going to link fatty acid oxidation disorders to diabetes? And one is that during diabetes, when somebody has way too much glucose on the outside of the cell, they end up releasing ketones, because ketones are the way that we get energy to the brain when we don't have another source. Now, in the case of diabetes, even though the blood glucose is really high, we can't transport that sugar into the cells. So even though the outside of the cells, we're pushing out all this glucose, because in the case of type 1 diabetes, there's no insulin receptors to bring it in, the cell is basically starving for sugar. And so in a certain sense, even though there's a lot of glucose on the outside of the cell, there isn't any on the inside of the cell. When the cell does not have glucose, it obtains energy from breaking down fats. And the fats are actually broken down in the liver and transported to the cells through ketone bodies. When we break down fats, the byproduct, like I said, we make ketones. And so when somebody has type 1 diabetes, you should see ketones in the blood and the urine, because that is a sign that the cells are finding a way to get energy. When someone is hypoglycemic, and again, hyperglycemia, we're talking about diabetes and the cell is actually starving. But when we have hypoglycemia, for instance, somebody doesn't have enough glucose in the bloodstream, we should always see ketones. And so if somebody is hypoglycemic, we should definitely see ketones, because that's the normal process of our body trying to maintain major, functions no matter what. So when we have hypoglycemia with no ketones, that's a sign of a problem going wrong, and the problem going wrong is fatty acid oxidation disorder. So let's go over fatty acid oxidation. And again, as I said with the other in the inborn errors, I know you have 4,000 things from biochemistry, and the genetics is going to be a little bit more limited because you don't need to hear the same thing twice. But the important thing is the genetics part's going to go through not just the inheritance, but what the clinical, consequences of this are. So again, we have our fats and we bring them into the mitochondria. So fatty acid oxidation occurs in the mitochondria. So we take our fats and we attach it to an acyl group, and we bring it from the outer mitochondrial membrane to the inner mitochondrial membrane. And then the acyl-CoA, which represents about 16 carbons when we're starting to break down the fats, they then are attached to carnitine and go to the inner mitochondrial membrane. So carnitine is a vitamin. It's also a shuttle. So when we have carnitine deficiency, we're also not as efficient as we should be bringing our acylcarnitines into the inner mitochondrial membrane, where during beta oxidation, and again, biochemistry has a lot of stuff on all the intricacies of beta oxidation. I'm not going to go through all those. But what I am going to say is each one of these steps makes a 2-carbon that goes into the citric acid cycle to make ATP. And each one of these steps, going from 16 to 14, 14 to 12, 12 to 10, 10 to 8, 8 to 6, so on and so forth, requires a different enzyme to break off those 2-carbon pieces that go into the citric acid cycle. Whenever there's a lot of enzymes that could be abnormal, there's a lot of different things that can go wrong. Long-chain fatty acid oxidation disorders known as LCHAD. Medium chain, known as MCAD, is a break between C6 and C8, so you see a big bump here on 8 because 8 can't get down to 6. So here's a normal mass spec looking at all the different species of the carbons, and they should look pretty even. Here's when we see a bump here at the C8. That's what we see at MCAD. And then SCAD is the last step between 4 and 2 to break down the fatty acids. Some people don't even believe this is actually a disorder. But now I'm going to talk about the most common of the fatty acid oxidation disorders, which is MCAD, or medium chain acyl-CoA enzyme A dehydrogenase deficiency. I just call it MCAD because, as you can see, I have a hard time saying all those words. Anyway, this is the most common of the fatty acid oxidation disorders, occurring in about 1 in 6,000 individuals. Medium chain acyl coenzyme A dehydrogenase, or MCAD, this enzyme is involved in mitochondrial fatty acid beta oxidation, and it's that step in the inner mitochondrial membrane that the C8 is broken down to the C6. So we went from 16 to 14, 14 to 12, so on and so on and so forth, and we've gotten our 2 carbons, so we do get some energy out of this, but when we get to C8, we can't get to C6. So we're not as efficient as we should be. Now there's a couple things that happen. One is, until we release all of our C2 carbons, the carnitine doesn't get released back up to get more carnitine. So the carnitine is stuck onto the acyl species. And so we have a carnitine deficiency. We don't have free carnitine to bring more stuff down. So that's like one problem. But the other thing is we're just not getting enough energy. And so we get hypoketotic hypoglycemia. Remember at the beginning of this lecture, I was talking about when you are hypoglycemic, you should be making ketones. That's normal. And so knowing what you should be doing, when you see something abnormal on a blood test, you should say to yourself, oh, I expect ketones because somebody's glucose is 40. I expect to see ketones. It's harder to remember, why don't I have ketones here? So hypoketotic hypoglycemia, and some people say this is like a Rye-like illness. A lot of researchers believe there's no such thing as Rye syndrome without some form of a fatty acid oxidation disorder. Organic acids that we talked about in the last section, and as well as these acylcarnitine studies, will show an increase in C6 to C10 dicarboxylics because we're not going from C8 to C6. Now, why is this important? Well, it's really important because 2 to 3% of SIDS, and SIDS stands for sudden infant death syndrome, are a result of MCAD syndrome. So how did they come about this number? Well, we actually look at fatty acid oxidation disorders on the newborn screen, and we do it by looking at the mass spec and measuring how much C6, C8s, and so on. Hopefully we get that normal pattern. I'll just pop back here. So hopefully we get this normal pattern. But if we see something like this, then we're concerned it might be MCAD, and then we do further confirmatory tests. But what they did is they went to the PKU cards, because they actually keep these blood spots for a long period of time, and this is before they did newborn screening, of all the babies in about 3 states that had died of sudden infant death. And sudden infant death basically means the mom went to get the baby in the morning and the baby had died overnight. And they found that 2 to 3% of them had MCAD that was undiagnosed, because it's, again, very insidious, and you don't know it till something often catastrophic happens, unless something else is happening. Unless you diagnose it in some other way. So the usual presentation of a fatty acid oxidation disorder is episodic illnesses of hypoglycemia occurring between 3 months and 2 years of age. And this usually presents with fasting of 12 or more hours, and or maybe an incurrent infectious disease, a viral illness of some sort. So what happens? The baby, young infants, eat every 2 or 3 hours, and they're not as good at maintaining homeostasis. They're, storing things. So they eat every like 3 hours. And then they get a little bit of a cold and a runny nose, and they're not eating as well. And they're really tired. And so, and they have a little bit of a fever that increases their metabolic rate. And so they go to sleep, and their glucose drops from 80 to 70 to 60. Now, normally, the body says, hey, let's grab some fats. Let's keep this going. But you can't do that because you have that enzyme block. And so the glucose keeps dropping, and eventually it shuts off the respiratory center, and the baby stops breathing. So acute episodes can start with vomiting, lethargy, or even seizures, and the seizures are because the brain doesn't have glucose. But they can progress to coma rapidly, and again, many times there are no symptoms. The baby just stops breathing. MCAD is inherited in autosomal recessive fashion, which means both copies of the gene need to be non-functional. I've talked about this before, but a lot of enzymes, usually if you have 50% of an enzyme, you're just fine. And if you have anything over like 20% of the enzyme, you probably be pretty good. So if you have 2 copies that are functional, you have 100% of the enzymes. If one one of the genes is functioning, then you have 50%. And if one of the genes is even functioning 50%, you're still got 25% and you'll be okay. So if you ever, just as kind of a clue, thinking about an inheritance pattern of some disorder that you have no idea what it is, if it's an enzyme and it's not located on the X chromosome, so I'll take that one out. If it's an enzyme, think recessive. If it's something structural like connective tissue, it might be dominant. But if it's an enzyme, it's probably recessive because one copy is probably enough. So LCHAD is another fatty acid oxidation disorder which occurs earlier. It's the long chain, so we get the bump in the long chains, and features are far more severe. Low muscle tone, hypoglycemia, and cardiomyopathy, because the heart is the most important muscle. They usually present more severely and earlier than MCAD. And then there's VELCHAD, which actually the initial breakdown of fats occurs in the peroxisome, which we will talk about next year, so I'm not going to go into detail about that. Short-chain acyl-CoA dehydrogenase deficiency, or SCAD, results in the inability of that last step. There's no hypoglycemia as seen with or SIDS, and it may not even be a metabolic problem. Like, it may be nothing. We diagnose it through the newborn screen, but it may or may not be of clinical significance. So a 3-month-old presents to the ER. The parents are having difficulty arousing the baby. He had a viral illness and has had poor oral feeding for the past 2 days. In the ER, the baby is noted to have a glucose of 52, normal being 90 to 110. Another thing I want to emphasize is whenever you're given numbers about labs, you always should be giving a normal because every lab has a different normal. The urine dip is negative for ketones. So again, I'm telling you, if your glucose is low, you should have ketones, which is a lot harder to remember than when something's abnormal. The most likely cause of this lethargy is a urea cycle defect. Well, in a urea cycle defect, I didn't really give you all the things from last week, that we went over, but I probably, if I was actually going to ask this on an exam question, I would give you that the kid was not acidotic or alkalotic. Maple syrup urine disease, you can have hypoglycemia, but you would have ketones. Galactosemia is, you might have hypoglycemia, but you'd also have ketones. PKU, you wouldn't have any of these things. So this would not be an ideal exam question. I just kind of put it in here. But those are the kind of things to think about when you're looking at this. So that concludes this brief lecture on fatty acid oxidation disorders.